Wow, what a great event. I've been part of this for the last 10, 15 years, and this has grown. It's great to see everyone in red. This is the only day I could wear a red shirt and be presentable. So uh, just a little bit about me. I'm an interventional cardiologist at Riverside Community for the last 25 years. We've seen the program grow. The STEMI program is incredible. So we really appreciate the hospital and what they've done to promote the STEMI program beyond other programs. We also have the TAVR program. I see some of them here sitting at our table here. Part of it, I'll talk about it. And of course, the other thing that's really important is the graduate medical education program. So we do have residents that we are teaching, and they're going to be part of our community through the hospital. So we really appreciate that. They're going to help us grow. We desperately need primary care and specialists in the Inland Empire. So I think that's great. So coming to what I was told to come here and talk about, and I was told to talk about, women's health and heart disease. Let me see if this works. Well, this talk was first to be given by my partner, Dr. Mimi Biswa. Some of you know her, and she's a proponent of a lot of preventive medicine in cardiology. Well, she couldn't make it, so I'm the second choice. And she couldn't make it for three reasons. Well, one was she had to take care of her kids, take them to soccer practice this morning, the usual thing on Saturday. Well, the second, she has to round and see patients. Today, we put her on call to see patients, of course. But the most important thing, her husband, who's also a surgeon, got sick with the most terrible illness. And she had to take care of him, too. It's called the flu. So she's at home right now doing all that. Well, just kidding. No, she couldn't make it here, so she asked me to fill in. So I was going to talk a little bit about a woman's heart and cardiovascular disease in women today. So this slide talks about the trends in cardiovascular disease, and it shows over the years. The red is the deaths in thousands for women, and the blue is for men. And you can see the deaths for men is lower, women is higher, but showing a downward trend. So certainly things like this, promotion by events like this, have promoted heart disease, especially in women, and done a great job. But there is still some things that really we need to look at still more. At this most recent meeting at the American Heart Association in November of 2018 in Chicago, this was a very compelling study that was done. And what they found that in women and men who are at a younger age, between the age of 35 and 54, that the risk of having a heart attack has increased from 27 to 32% in that age group. So we're seeing more people at a younger age get a heart attack, both men and women. But what was more disturbing was that compared to younger men, young women were less likely to receive the standard treatment, which is statins or cholesterol-lowering agents, beta blockers or drugs, and blood thinners, and of course coronary procedures. So even in young women presenting, we still have a gap between men and women at this age. Another very important study, and this ties in with Dr. Nahar said, they found that at the University of California, San Francisco, they looked at 200 pregnancies between 205 and 211. And what they found out was people or women who had postpartum depression, so these are young women who had postpartum depression, had a 3-time increase in cardiovascular disease in the future. Now, that doesn't mean that everyone who has postpartum depression is going to get a heart attack, or postpartum depression leads to heart attacks. What it really means is that they have significantly higher incidence of diabetes, hypertension, obesity, chronic kidney disease, high cholesterol, smoking, and drug use. And what this study really emphasizes is that we need to have a closer collaboration between the gynecologists and obstetricians, like Dr. Nahar's, primary care physicians, and cardiologists. So there's so many things or aspects about women's health that we really need to look and focus on that these two studies tell us. So I just want to put this out. These are very, very important recent articles or journals that came up here. So why is there an issue difference between men and women? Well, some of this has been alluded to. Women are 15 times more likely to die from cardiovascular death than breast cancer. It's the number one killer, as we talked about. Over 500,000 heart attacks deaths. There's a high disability. That means people who have a heart attack, they may live, but they have disabilities. They may have had, they're not able to get back into meaningful work. And cardiovascular disease outnumbers the next 16 causes of death in women combined, including cancers. And this is startling. 1 in 2.5 women will have a cardiovascular event annually, which includes a heart attack and stroke. So this slide also again tells us coronary disease is the new red. This slide talks about white females and black females. On the left-hand side, you're seeing the heart attacks people get. And then strokes, lung cancers, and breast cancer are far small as far as a percentage. So what are the facts? Well, these are not the so fun facts. Almost 2/3 of women die suddenly and have no forewarning symptoms. That's important. The slide that you saw, the lady who was having chest pain had no symptoms at all before. The first sign was a sign of a heart attack. A really, really important concept to realize that most people that have heart attacks don't know they're having one till they're actually having one. They have no symptoms of chest pain, shortness of breath before. 37% of women have an event, will die within the first year. Usually they die of heart failure, they have arrhythmias, or they have an irregular heart rhythm, or they have a weak heart. And 35% of women will have a second heart attack within the next 6 years. Well, women are unaware so why exactly are there problems? Why is it so different than men? Why are they undertreated? There are many reasons for this. This is not one problem itself. Women are unaware of their symptoms because they are different. And I'll get a little bit into these symptoms that are different. They may be uninformed of their risk of heart disease, and they may also, the physicians who are treating them may be uninformed. 1 in every 5 primary care physicians in a survey was unaware that cardiovascular disease is the primary killer. Then they may be underdiagnosed. That means they may present the same way, but they don't get the same test, which the most recent study as of just recently showed that. And finally, even if it's diagnosed, they may not be treated appropriately with cutting technology that is needed for them. And finally, women have anatomical differences in the coronary arteries that make them most susceptible to having heart attacks. I'll just skip on to the slide. What are the symptoms that they have? Well, one size does not fit all. Chest discomfort or chest pain is still the most common cause of symptoms that they present in women. However, they may have other symptoms, as was evident on the slide. They may have fatigue, they may have shortness of breath, they may have weakness, and these may be non-specific. They may be looked at as not related to the heart. And that's one of the reasons why many of the time when they present, they may not get the treatment in the same rapidity as they should. This slide talks a little bit about symptoms. On the left, you're seeing what happens in women, and on the right in men. And it shows that most men and women do, 75% of them, 75 to 80, do have chest pain, the traditional symptoms. But when you look down, 37% of women have neck pain compared to 22%. Upper back pain in 34% and men 26%. And jaw pain 24% in women and 12% in men. So many of these symptoms of jaw pain, back pain, neck pain can be misrepresented, and they may think they're having tooth pain, they may have back pain, arthritis pain. So it can be overlooked sometimes. In fact, just recently I had a patient who had neck pain for 1 year and was sent to chiropractors and orthopedic doctors and finally was diagnosed to have heart disease. Now that doesn't mean everyone, I do want to warn you, I don't want everyone to worry that if you're having these symptoms, they could have problems. As far as stroke, it's important to recognize strokes. This was talked about actually as far as the stroke center that Riverside does. And I'd like to say that recognizing stroke, be fast. If you have symptoms of balance, you've lost vision, you have uneven face, or you have arm problems, or you have weakness in one side, speech difficulty, time is of essence. Call 911 because they can take you to the hospital and give you blood thinners or do an embolectomy. I'd also like to talk a little bit about some of the work that we're doing at Riverside Community Hospital. There are some brochures on your desk about the TAVR program. Riverside Community not only works on preventive, but also in trying to deal with other diseases, including aortic valve replacement. This is specifically important. In the traditional way, people who have a narrow valve, the aortic valve, over time were subjected to an open heart procedure to replace the valve. We now have another procedure called a TAVR, transcatheter aortic valve replacement, where through the groin, through the femoral artery, we can put in an artificial valve, and these patients do well. This is very important, especially in women, because they are smaller build, they may have other conditions, and they may be more suitable for this procedure. So we really appreciate the efforts taken by the team in this important procedure. So in summary, let me go back. In summary, women don't present like men with regards to a heart attack. They have more complications. They have atypical symptoms. Weight loss, smoking cessation, and exercise can save your life. Early and timely diagnosis is key. And consult with your primary care doctor if concerned. I have two more slides. I think about 30 seconds, and I'd like to share this slide because this is also a new slide that has come up, and I do get asked this a lot of times in my practice when I see patients on cholesterol. And these were the new guidelines that came out. So I thought it would be important to share these with you because these are somewhat different than what you've been traditionally been told. Most of my patients know what their cholesterol numbers are. They look at that number and they have a score that they do that. But the most recent guidelines which came out a few months ago from the American Heart and American College of Cardiology, they emphasize that having high cholesterol at any age increases the risk of cardiovascular disease and recommends early risk assessment even amongst children and young adults. There is no target for ideal LDL. LDL is the bad cholesterol. And the principle is the lower the better. And the shift in care is from simply knowing your cholesterol to now personalizing your risk. Everyone is different, so we can't really have one size fits all. So these are the new guidelines. And what they really talk about is people who've had a heart attack who had secondary prevention. So by secondary prevention means someone who's had a stroke or a heart attack, they need to reduce their cholesterol by more than 50%, the bad cholesterol. So it's not really about getting a number, it's reducing it by less than 50%. So even if your cholesterol is within normal, you needed half of that because that normal number was not good enough for your body. And the two drugs that they talk about are atorvastatin and rosuvastatin. Please talk with your cardiologist or primary care. But what I want to emphasize is that it's now a percentage really of reduction rather than an actual number. And the second new change that has come about is that they've talked about adding on another drug called Zetia to the regimen of a statin of this cholesterol. Or now we have some injectable forms which are called PCSK9, which are long-acting monthly injections to be given along with a statin if you don't get those goals. So really the emphasis on extremely aggressive correction of your cholesterol across the board. What about people who've not had a heart attack but at high risk for having a heart attack? These are people who have what we call primary prevention. They've not actually had a stroke. And really what it talks is starting a statin or to include a discussion on the major risk factors. So if you have high risk factors, you want to be more aggressive. If you have low risk factors, you don't need to be that aggressive, but still should be on a statin. And what they talk about is for adults aged 40 to 75 who don't have diabetes to have a reduction of bad cholesterol of 30%. And those patients who have diabetes and in that age range should have a reduction of greater than 50%. And finally, I guess I did put this up because this is also a little different than the previous studies, is that those patients who have what we call intermediate risk, that means they are not high risk like a diabetic, or not low risk and who don't have hypertension or diabetes, but are somewhere in the middle, they could get what's called a calcium score. These are calcium scores, CAT scans that are done. In the past, we have not been promoting them that much because we weren't sure about the relevance of that, but now this has made it into the guidelines. Not everyone should get it. It's only those who are somewhere in between. So I did want to emphasize some of the newer studies because I know this comes up a lot to some of my patients there. Well, I hope you enjoyed the talk. I hope I didn't make it too boring for it. And we have a great time here. You've got the fashion show, which is amazing. So thank you very much for your attention.